My name is Sue Vogel. I'm president of the Staff Retirement Association. We are co-hosting this meeting with the Retired Faculty Association, but we could not do it without the Emeriti Center. And I have a kind of interesting anecdote. I was walking my dogs with a USC colleague yesterday, and I said, we're going to have this lecture with Stephen Chen. She goes, Stephen Chen? I interviewed him. He has all these great anecdotes. And she starts telling me stories about community pharmacy and how he literally paid a house call to this guy who was living in a trailer on a lot, not taking his medicine. She said he has great stories. So I got very excited to do this. So I will just tell you the title, and it is Optimizing Medication Therapy in the Age of COVID-19. This goes to two things we care about: our health, our money, and also COVID. And it is the third in our ongoing Distinguished Lecture series. The first one had to do with racial justice, the second one with presidential transition. So I think this third one will be just spectacular. I'm really excited. And I'm going to thank Sandy Boulevard for suggesting this topic and for everyone that helped put it together, especially the Emeriti Center staff. I'm going to turn this over to Jerry Walker. He's president of the Retired Faculty Association, and he will introduce our speaker. Oopsie, just a second.
You forgot something.
I did. I forgot to tell you all, we are going to have a nice long Q&A time. Put your questions in chat, and Jerry and I are going to alternate reading your questions after Dr. Chen speaks. So please put your questions in chat.
Well done.
Jerry.
Okay, thank you.
You're welcome.
I wanted to introduce Dr. Stephen Chen. He's Associate Dean for Clinical Affairs at the USC School of Pharmacy, Professor of Clinical Pharmacy, and holder of the William A. and Josephine A. Heers Chair in Community Pharmacy. I thought maybe I'd take just a moment to let you know the extent of the responsibilities of being an Associate Dean for Clinical Affairs. He has oversight of all clinical training provided to USC students. And he also has oversight of clinical services of faculty, staff, and residents in the Los Angeles County USC Medical Center, the Keck Hospital of USC, and the Norris Comprehensive Cancer Center. So he's a very busy man. He's principal investigator for more than $18 million in grant-funded research, evaluating the impact of comprehensive medication management on healthcare quality, safety, cost, patient satisfaction. He is co-chair emeritus of Patient Safety and Clinical Pharmacy Services Collaborative. That's a mouthful. It is part of the U.S. Health Resources and Services Administration. And he is the founder of the California Right Meds Collaborative. He is a winner of a number of awards, among which are the American Pharmacists Association Pinnacle Award and the American Association of Colleges of Pharmacy Inaugural Community Transformative Award. And he has received the USC School of Pharmacy Outstanding Alumnus of the Year Award. I will stop there because the American Heart Association has also acknowledged his fine work. So, Dr. Chen, the floor is yours.
Thank you very much. I have to tell you that my only goal in life has been to accomplish maybe a quarter of what Dr. Williams has done, and here he is on the call. So what a pleasure it is to have my mentor on this call. All the tough questions I'm going to ask him to answer. I've been asked to give this presentation. Hopefully this graphic makes some sense to you. You know, we have this healthcare system that has already been struggling somewhat, and now we add COVID to the mix. You know, what does that mean for people that need good care the most? And I think that includes this group. And I'm going to lump you lump myself with you, because I'm actually not so far from retirement myself. So, you know, I want better care for my healthcare system. Hopefully I'll share with you some ideas on how to get that accomplished through pharmacy. So this is sort of the map I'm going to follow. Talk a little about things that you probably know already about, some of the problems we have in our healthcare system, giving a bit of a focus or definition on medication safety, talking about some solutions that work that I hope will relate to you, and then a little update on COVID-19 vaccination, which, by the way, I want to tell you, whatever I say in this hour will expire by tonight because everything is changing so fast when it comes to COVID and vaccines. Just a little bit about me so you know who I am. I am a graduate from the USC School of Pharmacy. Again, Brad Williams was one of my professors. I had probably my worst patient care experience ever under his training, and he quickly fixed that. So thank you. He put me on the right path to doing what I do in my career. I'm a primary care clinician by background. So I basically get patients sent to me who are the most challenging in any healthcare system. They have uncontrolled chronic disease. They're just not getting to goal. My job is to figure out why. Is it the medicines? Is it something the patient is doing wrong? Is something being prescribed different that could be done better or differently, right? I come in there, basically make that assessment and make changes to drug therapy, follow the patient and get them to goal. I worked for the VA for about 10 years. I love the VA. It gave me a lot of opportunity to be a primary care provider and learn my physical assessment skills. And then when I joined USC, I moved to Beverly Hills Cedars-Sinai and saw a completely different level of care. They're an amazing place. I have great respect for Cedars. I learned an awful lot about how to be excellent in clinical care. And then I jumped to the opposite side of the tracks. I was recruited back to work for the underserved. For the next 15 years of my career, I worked for a safety net clinic on Skid Row, basically serving homeless patients. And what I learned is that it doesn't matter what your insurance is. It could be Cedars-Sinai, Beverly Hills level, could be VA, could be Skid Row. Medication-related harm is everywhere. I guarantee you that. And that's a very frightening concern, which I'll talk more about later. And these are my two kids. I have a college-age kid and somebody that's about to graduate from high school. Yeah, they're a funny bunch. They look about the same as they do in these photos, just really long hair now because nobody's gotten a haircut in quite a while. So, it's funny that you mentioned, Sue, patient care experience. I'm going to share with you a couple of examples of what I'm talking about. Why do I have a picture of a refrigerator? That patient you were mentioning is exactly why I have this picture up. So one of my early experiences, working in primary care is I had a patient referred to me who was taking insulin, and despite continuing increasing doses of insulin, the patient's blood sugar wouldn't go down. So I evaluated this patient in the clinic. I figured out that he seemed to know what he was doing, but something was wrong. So I decided to go and do a home visit. Went to his address, which I think it was in Watts, that area. Found the address, but I couldn't see any house. So I went to the gas station next door. I said, "Can you tell me where this address is?" And he said, "Who are you looking for?" And I gave him the name. He goes, "Oh yeah, right here." So he walks me over to this empty lot, all boarded up, pulls the board open, and there's a trailer, an abandoned trailer that my patient lives in. So I went to go see him, did an on-site quick evaluation of his vital signs, everything else. I said, "Hey, we've given you extra insulin. Where do you put the insulin? We told you to store it in the refrigerator. Where do you put it?" He goes, "Yeah, it's in the refrigerator." And this is not the actual refrigerator, but in a refrigerator with no door, in the middle of summer, he had put his insulin bottles and baking in the summer heat. So what was happening was, he was basically, I guess, disabling his insulin, right? Cooking it to the point where it wouldn't do anything. Did everything right. We said refrigerator. We didn't tell him it had to be plugged in, right? At the end of the day. So pretty interesting and eye-opening experience in the early part of my work with the underserved. Another quick story I'll share with you is I had a patient at Cedars-Sinai who just wouldn't come in for an appointment despite having heart failure. The cardiologist was concerned, so I did a home visit. Went to go see her, knocked on her door. She knew I was coming, and I was about to leave because it was almost 5 minutes and nobody was answering. She opens the door, just huffing and puffing, and she walked about 10 feet to open the door. So I took a look at her, did a quick assessment. She had 4+ pitting edema on both sides of her legs. Her legs felt like they weighed at least 25 pounds. So much water being retained. Obviously, she was fluid overloaded. So we worked with her. We're able to get an increase in her water pill, her diuretic, and got her flushed out, got her breathing within a few hours. I can't say it was a success story in the end because I think she passed away soon after that. she was not doing well. But the point is that these are the kinds of patients that I see all the time who are struggling with chronic disease control, and despite having very good health insurance in many cases. So with that in mind, just wanted to remind you of something you probably already knew. Healthcare is dangerous in this country. When you look at this graph of the number of encounters per fatality on the x-axis and the total lives lost per year on the y-axis, we want to be at nuclear power, right? There's many encounters that are required before someone dies, and very few people die related to nuclear power, down here in the lower right-hand corner. Unfortunately, healthcare is here in the worst quadrant of all, where we have many lives lost per year with very few encounters before that happens, right? We have a dangerous healthcare system, bottom line. It's also, as you know, super expensive. This is a bit old. If you add about 40% to the cost that you see in the bottom of this chart, no question, we spend probably 40% more than any other country in the world on healthcare. And our quality is dead last when we look at how we compare with our peer countries. So we spend the most and we get the least, right? And so far it's not sounding so good. And a big part of that problem is pretty lousy preventative health in this country, right? We have very high rates of obesity. Half the population has chronic disease. It accounts for 3/4 of all doctor visits, 80% of hospitalizations, and 90% of all prescriptions filled. So this is a big problem. I think all of you know that. You add COVID to the mix, and now if you have uncontrolled common chronic diseases and cardiovascular disease, diabetes, respiratory, and you get a COVID infection, your chance of being hospitalized or even dying go up markedly, right? So what COVID has done is it's magnified our already poor healthcare system and the outcomes that we get from it, right? And I'm probably preaching to the choir, but this is a fact. And a big root of the problem we're talking about here are medications, right? 90% of chronic diseases require optimal use, prescribing and use of medications to get the best results. Okay? And we just don't do a good job with that. What this is showing you is because of the way we fail to optimize medications, it's costing our country over $500 billion a year, 16% of all healthcare costs. It's the 4th leading cause of death in the US, our failure to optimize medications. It accounts for 3/4 of possible admissions, and we can go on and on, but there is a problem with our utilization of drugs. Now, I'm not suggesting that drugs will fix everything. We need to fix our preventive healthcare system much better. But right now we are bleeding. We're bleeding money, we're bleeding lives. People are harmed. People are not getting the care they could get because we can't get the medications right. So speaking of that, I'm going to zero in on, I think a big issue, especially as we all get older and we get more chronic conditions and get more medications, and that's medication safety. A lot of people are harmed because of medication safety. And here's some stats that relate to the graphic I just showed you. Over half, 60% of all med errors occur during what's called care transitions. That's when you move in and out of the hospital, you move in and out of nursing home care. Anytime there's a transition in healthcare, there's a drop off in medication continuity, and we get errors that occur that can harm patients. 1 in 5, 20% of discharged patients from hospitals experience a side effect. Are they all bad? Well, some are. Some actually bring them back to the hospital. And again, almost 3/4 are due to medications. So we need to do a better job of making sure that when patients leave the hospital, that they have the right set of medications that don't interact with the ones they have at home, right? That happens all too often. And as I said before, 3/4 of hospital readmissions can be attributed to medications not being used well. This just points out that that's a very frail part in our healthcare system when you're being handed off from one system to the other. Ooh, this could be a little boring, but I'll try to make it easy. Okay, I'm going to start talking about some terms about medication safety. I want to make sure you know what I'm talking about. So I think we all know what a medication error is, right? It's a mistake. It's a preventable event. It can happen when the physician does something, when the pharmacist does something, when the patient does something. That's a medication error that leads to harm to the patient, right? I think that's pretty easy to understand. There's a term I want you to understand, which is adverse drug event, or ADE. This is injury resulting from use of a drug. Any injury resulting from use of a drug. We want to be able to prevent ADEs. We want to stop them. We want to find them, and we want to stop them from happening. Within that subset of harm from a drug, there's harm that occurs even when using a drug at the right dose and during normal use, right? So think about what that means. If a physician or pharmacist gives you a medication and you're using it exactly the way it should be done, you could still have a side effect, right? Now, of course, if you take too high a dose, you're more likely going to have a side effect, right? But ADRs, average drug reactions, are referring to in the normal use of medications, you still get harmed, right? But what I'm trying to say is that we want to try to minimize that as much as possible, but we want to try to identify all average drug events and resolve them as soon as possible so they don't cause further harm. The other term I want you to recognize is potential adverse drug event, PADE. These are the near misses. This is when the pharmacist is filling your prescription and realizes, oh, wait a minute, this new drug that was just prescribed interacts in a very harmful way with these other drugs you're taking, and acts at that point to stop those drugs from being filled, right? That's a potential adverse drug event because they stop any harm from happening before it could occur. Okay, so the real zeroing in on, as I talk about these things, is adverse drug events, finding those problems that you're suffering from that are because of drugs that you don't even know about. It actually does happen, believe it or not. And then potential adverse drug events, those things that we try to prevent from happening to you. Okay, so I'm going to refer to these as we go along here. Now, sort of to the question of, I've already painted the picture of there's a lot of harm out there from not using medications right. You're putting a lot of good care, good health off because sometimes medications aren't being prescribed well. How do we fix that? How do we make sure that you have the right medications that are taken at the right doses, et cetera, for your health? Well, part of it is many health systems hire pharmacists to specifically do that. So Kaisers, VAs, many medical clinics, including USC, hire pharmacists specifically to help patients who are struggling to get to control their chronic diseases, to evaluate their medications, to work between the patients and their physicians, to change doses if necessary, to change medications if necessary, to monitor and order tests, to monitor vital signs, and make sure everybody gets to control of their chronic disease. Pharmacists specialize in doing that, and there are many systems where that does happen. It's also done by phone. It's also done by video, right? COVID has been a bit of an innovation leader in a way in getting more video and phone telehealth care available, and it can be done very well. Clearly, in the examples I showed you, the patient with heart failure, you'd have to make that assessment in person, the fluid overload. But there are many assessments that can be done very safely by phone and video. And then the other one that I'm going to talk about eventually is we have 67,000 pharmacies in the US. That's 4 times as many pharmacies as there are Starbucks. And in most of these pharmacies, you have a limited set of clinical services. We're working on a program, which I'll talk about later, to expand the role of those pharmacists in the community in providing the kind of care that we're talking about in this presentation. There's a name for that care, by the way, the care where a pharmacist manages medications on behalf of physicians in partnership with physicians and patients. It's at the very top here, comprehensive medication management. Okay. So I'm going to give a couple of examples of what this comprehensive medication management looks like in practice. Now, I know that the initial ones may not be relatable to you directly, but I think you'll appreciate the impact on the community. And then I'll share an example that I think you will relate to. So this one is going to zero in on a very simple fact. I hope every one of you on this call has blood pressure at goal. I really do, because it isn't hard to do. We have the first 4 or 5 lines of medications for high blood pressure that are generic and dirt cheap and widely available. We have no excuse for where we're at right now. We only control blood pressure in half of our population. It's really a shame because it accounts for half of all heart attacks and 3/4 of all strokes in this country, right? Yet we're only at 50% control. We should be doing much better than that. In fact, I'll share this with you. In Canada, in the early 70s, the US and Canada were at about low 20% control of high blood pressure. Today, Canada is approaching 80%, and we're still at 50%, in fact, below 50%, right? There's no reason for it because it's not a complex disease to manage, right? Add to that there's a population that suffers the most from uncontrolled hypertension. It's the Black man in particular. You can see that death rates from hypertension are much higher in Blacks than whites, and both men and women, but men in particular. Whoops, sorry. And there are many famous Black men who died very young as a result of uncontrolled hypertension. John Singleton being the most recent, who died from a massive stroke at the age of 51 from a very preventable outcome. Again, all largely tied to high blood pressure. So in a program that we were working with in Los Angeles, run by the late Dr. Ronald Victor from Cedars-Sinai, he proposed that we could do better by identifying Black men in barbershops with high blood pressure and getting their blood pressure controlled in that setting. But he didn't quite know how to do that. So we had met, and I said, hey, how about if we send a pharmacist in there? And he looked into it and he said, this is a great idea. So the idea was the barber will be the one to screen his patrons for high blood pressure. He would find patrons with sustained high blood pressure. He'd call in the pharmacist through Cedars-Sinai to come in to the barbershops to manage that blood pressure through an agreement with the physician, where the pharmacist literally takes over care and prescribing of medications. That takes away something that we see, which is where physicians who are so overloaded and don't have time can't pay enough attention to that blood pressure and manage medications accordingly. And by doing that, we get better treatments, adherence with medications, and better outcomes. Sounds like a good idea. Did it really work? Yeah, it really did. So Dr. Victor was able to work with us to get some pilot data that had able to get $8 million from the NIH to fund this study. Published it a couple of years ago, shortly before his passing, unfortunately. And here are the results. The bottom line is that patients that got their medications managed by a pharmacist for high blood pressure got 90% control of their blood pressure versus 32% usual care. And keep this in mind, 85% of all patients had health insurance. These are not patients that were all without health insurance. And 25% were Kaiser. Okay, so I think that might surprise you. The bottom line is night and day differences, having a pharmacist manage really what should be a very manageable chronic condition that our health system doesn't do a good job of. So just one example of how this works. Another is we did some work with a group called Ultimate Health Services, the largest private Medicaid provider in the nation. And basically we tested what happens when you have pharmacists embedded into medical teams providing comprehensive medication management. Again, basically taking over, in a sense, management of drug therapy in partnership with physicians to get patients with uncontrolled chronic disease to goal. So these were the components. I'll just lay them all out. We had 10 teams, clinical pharmacy teams, working together as a part of the medical clinics with Ultimed. We had a video telehealth team where pharmacists at USC would tap into some of the smaller clinics that didn't have the square footage to have the pharmacist on site. We trained residents and pharmacy technicians for this role. We created all sorts of trainings for pharmacists to advance their skills in this area. And at the end of the day, we wanted to see, does this lower costs? Does it improve quality? Does it improve access? Are patients happier? Are physicians happier? And the short answer is yes to all. You worked out very well. Just for, what did we do? I'm trying to explain now very well, what exactly is a pharmacist doing in this context? There are a lot of choices for medications out there for any given diagnosis. I think you all know that. Is there a right choice? There certainly are better choices, right? A simple example, I'll give you one that I think you can all relate to. There's a drug called hydrochlorothiazide for high blood pressure. How many of you are familiar with it? Can you just raise your hand if you're familiar with hydrochlorothiazide? Yeah, many of you are. So it's probably the most common water pill diuretic for high blood pressure. There's another one called chlorothalidone. How many of you have heard of that? Aside from Dr. Williams. Okay, so yeah, it's also in the same class as hydrochlorothiazide, but it's 30 to 50% more potent and it's longer lasting. And the results from it are better than hydrochlorothiazide. Most physicians don't know that. There are best choices when it comes to medications, even within the drug classes. That's what pharmacists key in on. They also zero in on dosing. Probably one of the most common mistakes I see is when patients get antidepressants, they get very low doses that don't help at all, and they stay on those doses. Right? Pharmacists are able to make sure that doses of medications given to patients are optimal and safe. They also, I mentioned this before, make sure that the mix of medications are safe, given other medications the patient is taking and other comorbid conditions. So drug-drug disease interactions. And then really importantly, can the patient use the devices that we're giving them? Some are easy and some are not. And I can tell you, even between Cedars-Sinai and Skid Row, I had the same problems with patients struggling with using some of these devices. And then I think what interests this group is the pharmacist makes sure that the medications are affordable to the patient or within what they want to pay. There are plenty of opportunities to go generic. And I would say for high blood pressure, if you're paying for a brand name medication, you really don't need to. It's not any better. And the evidence for the generic drugs is outstanding. So just to kind of go along with that study I mentioned that we got involved in, that $12 million project, we showed that we saved lives in a matter of a year, which is pretty surprising given that it was only 6,000 patients. So this work, optimizing medications, does translate into saved lives. And then you might be wondering, what is the pharmacist doing exactly with these medications? And this chart summarizes it for you. We enrolled about 6,000 patients in this program. We caught 11.5 drug-related problems per patient. So think about that for a second. Yeah, okay, Sue, I love your reaction because it's shocking. And so you might be thinking, well, were they little problems? Well, this chart shows you they weren't little, right? The biggest problem we found is that the drug treatment was not appropriate or effective. That means probably not the best choice of drug and maybe not the best dose that would actually work. And in some cases, believe it or not, diagnoses that were not even being treated, right? It happens in this healthcare system that's a bit complex and fragmented. So most of our activities were adding medications, adjusting doses, starting patients on something they didn't even know they needed, right? That was the most common thing we did. We did catch patients not taking meds. You can see from this chart, that's true. We did catch those safety issues I mentioned, the side effects and the near side effects. But by and large, prescribing and use of medications by prescribers was the biggest problem. Now I show this to you, I know there's a lot of detail on this, but let me explain why I am. Because we looked at the patients that got hospitalized. What caused them to be hospitalized? And you can see that we saw a lot of things like the dosing was too high. Patients were getting two of the same drug or multiple of the same kind of medications that caused them to have problems. The directions were not right, given what the patient really should have been doing, drug interactions, and so on down the line. So this is just a mix of the things that we caught and fixed for these patients that ended up getting hospitalized related to medications. Another one is back to the safety issue. Remember, ADE are the adverse drug events, the actual harm from medications. PADEs are the near misses. What do we find? Well, we found a lot of excess dosing, again, doses of medications that were too high for the patient. ADR is the actual side effect at a normal dose of medication. Again, polypharmacy, so too many medications to treat the same problem, didn't need them all. Medications being overused or misused. Dose discrepancy, I think that's an interesting one. That's where the patient is taking the medicine in a certain way, but the doctor thinks that they're taking them another, right? There's just a different opinion or view of what the patient is doing. Caught a lot of those. So these were the most common safety issues that we caught in this program, which are actually common in other systems as well. And then some of you may recognize these drugs, and I'm sorry I abbreviated a couple of them. Insulin, warfarin, the anticoagulant, the blood thinner. SFU is sulfonylurea, like glipizide, glyburide, drugs for diabetes. ACE inhibitors and ARBs, like lisinopril, losartan. Statins, I think we all know. And BB is beta blocker. These are the most common drugs causing side effects and problems, right? So some of you may recognize them. There's no question, especially with insulin, for example, that if you make a mistake on dosing and give a little too much, you can throw a patient into hypoglycemia, low blood sugar, which is a medical emergency, right? Things like that. Warfarin, similarly, the blood thinner, needs to be dosed exactly so, because too high and you can bleed, too low of a dose, you can have a clot and have a medical emergency. Anything that messes with blood sugar, you have the potential to cause low blood sugar. And then for the ACE inhibitors and the beta blockers, again, dosing it too high could just bottom out your blood pressure, cause side effects, and so on. So again, this is probably a universal list of the most common drugs causing side effects in a given population of patients. And this is what I just said, just going into each of the drugs, what are the common problems that you experience with them. Of the statins, here's a tip, and I'm sure Dr. Williams will agree. If there's a statin I don't like seeing used, simvastatin, because it's got a lot of side effects related to it and a lot of drug interactions, then some of which are with very common drugs. So if you're taking it, don't stop taking it. But I would consult with your physician about whether there are options that you could take. The other statins are fantastic. So kind of leaving that clinic environment, one of the issues we have in our population is getting to clinic is not easy, right? I worked in Skid Row for 10 years. We've worked with a number of safety net clinics. And this scenario is very common. The idea of we can't get that patient back to see us. How are we going to see this patient? And it's because they struggle with social support, with transportation, all sorts of barriers that you and I probably have not experienced in our lifetime. Something that I saw very commonly. The other thing we saw quite a bit was, and I saw this in the clinics I worked in on Skid Row, where physicians would prescribe a regimen, a treatment for the patient, everything from the actual drugs to what the patient has to do. And the patient walked out of the room saying, that's not going to work for me, right? I don't have transportation. I don't, that conflicts with my work. I work at nighttime. I mean, the disconnect between what I think sometimes healthcare professionals are trained to do and what patients can do with limited means is quite large. So, because of that, we decided to start something called the California Right Meds Collaborative. And this is something that was stated a little bit earlier. This is the idea of taking those 67,000 pharmacies across the nation and making them centers where patients can go in their own neighborhoods and get comprehensive medication management. They can go to their pharmacist that they see 2-3 times a month in many cases in these neighborhoods, and have the pharmacist get them to better control their chronic disease by working with them and their physicians on their medications. That's the vision of it. Not only that, but these pharmacies are being trained to become hubs for social support services. So if they need a particular social determinant of health assistance, the pharmacies are able to give them that resource through the health plans they work with. So the vision of it is the health plans have very sick patients, the high risk, and not so sick patients, the low risk. They identify those high risk patients. We work with the health plans to create these networks of pharmacies in these neighborhoods. The health plans refer those high risk patients to these pharmacies. The pharmacies get paid if they're successful with these patients, so it's a value-based payment. And then we're getting schools of pharmacies to coach these different networks of pharmacies to help them be successful. And it's going on right now. It's actually going really well. LA Care and Inland Empire Health Plan are our first 2 partners, and we have about 6 health plans that are interested in joining this year. So more to come. It's a very exciting endeavor. So here's one I think that will relate to you. I know that so far I've been talking about these services that could relate to underserved populations. This is a report. I know it's a little small, so I apologize, but I wanted to show you how detailed it was just because there's so many medicines this patient is taking. But this was a patient who was referred to me by a state medical leader. It's actually her husband. He's in his 70s. She said, my husband's a Kaiser patient, and I just feel like he's not getting good care. Can you take a look at his medications and do a comprehensive medication management consult? I thought this must be a test. This patient has Kaiser insurance. I don't think there could be anything that bad, right? Kaiser's the closed healthcare system. Everyone knows what each other is prescribing. So I took a look, not expecting to see anything. You can see that this patient has over a dozen health problems, including high blood pressure, prediabetes, gout, COPD, and well over 20 medications. And after I reviewed everything and I spoke to him, I was shocked. There were 4 major drug-related problems this patient was suffering from, including an overdose of a hypertension pill that is shown to be harmful if taken at doses too high, that actually worsened his gout. His gout hadn't been checked in 3 years. His last level was 10. It needs to be less than 6. He was on several medications that raised something called serotonin, and he had every symptom of serotonin syndrome except death. And he was taking medicines for a COPD, only 1 of 4. And the one he was taking was not the most important one. So again, my point is, whether you have good insurance or not, whether you have a spouse who's a physician or not, you could be someone suffering from medications that could be much better. Within this list I didn't even mention. There are at least 2 or 3 medications that are treating side effects of other drugs. So I would encourage you, boy, hey, Brad, I should have them go to you. Dr. Williams is a master expert at what I'm talking about here, but go to your local pharmacist and ask them for a checkup, for a tune-up like you do for your car, at least every year. Have them take a look at your medications, make sure that there aren't any major issues. Because this patient just went on and on with Kaiser thinking everything was fine, and we found quite a few problems. So I'm going to just take a few minutes to cover COVID-19 updates and then open it up for questions. Again, what I say now will expire in the next 20 minutes. That's my warning. So as you know, as of tomorrow, I think, we will have 3 vaccines. The FDA is looking at the Johnson & Johnson vaccine. We currently already have Pfizer and Moderna. The Pfizer and Moderna vaccines are very similar. They're both 2-shot vaccines. The game changer with Johnson & Johnson is it's a single-shot vaccine and actually very effective. I think some people misunderstand and think that's less effective. It's highly effective at preventing COVID illness and death. In fact, I believe there were 0 deaths in the treatment group in the Johnson & Johnson study. What are the differences? Not much. At the end of the day, these vaccines all create antibodies to the spike protein. The way they do it is a little bit different, but at the end of the day, that is the end product, antibodies to the spike protein of the coronavirus. Now, how are we doing as a whole? Well, as of late last night, I took a look. We're at about maybe 13, 14% of the entire US population having at least 1 shot of the vaccine. Think about that for a second. We started in late December. We're at about 2 months now, and we're at best maybe 14%. Let's round it up and say 15%. Okay. So if we want to get to herd immunity, what are we supposed to get? About 75%. We're not on a great pace right now. Now that's the bad news. The good news is, I think as of late, we've had much better coordination between the feds, the state, and counties, and we're seeing an acceleration of this process. And now, with that 1-shot Johnson & Johnson, we could be in a different place in a month from now, or a month and a half from now. So I'm really excited to hear that. The vaccine manufacturers this week gave some testimony to Congress, and what they said is, we will deliver 220 million vaccine doses by the end of March. That's really important because as of today, they've delivered a total of 75 million. So we're seeing a lot more vaccine coming in very quickly in the next month or so. I think we're going to be in a good place much sooner than people are thinking at this point. So what about California? How are we doing? We're kind of average, okay? So we don't have a large percentage of our population vaccinated. We're a huge state, right? That's one of the issues that we have, and our vaccine supply has not been very good. The good news in places like LA County, San Diego, is that we've been actually pretty good about getting available shots into arms, like right around 90%. That's important. In the very beginning of this pandemic, when the vaccines were coming in, only 1/3 of shots were getting into arms at any decent kind of efficiency. But at this point, LA County, San Diego, Orange has been very good about getting vaccines in, getting them out to the vaccination sites and getting them into arms. A lot of it has to do with these big mega vaccine sites that you're hearing about. Dodger Stadium, Pomona Fairplex, Cal States, all those locations are massively getting vaccine out very quickly. So that part is good news, but we have 40 million people in this state. We're not quite there at 8 million or so of vaccinations that have been administered. But like I said, this next month, I think we're going to see a big pickup in that. Where are we at in terms of who gets a vaccine? Well, starting Monday, we have a new tier coming up. If you look down here in the bottom, we're going to expand into tier 1B, tier 1. We're going to get into all of those people, which will include education, childcare, emergency services, and food and agriculture. That's going to be a big jump in terms of people who are eligible. And that's good news, right? These are people that are very high risk and need to be vaccinated as soon as possible. I think that's all the good news in terms of where we're headed. Obviously, we were a little slow to begin with, and things are getting a little better at this point. I have a huge worry, and that worry is that I am concerned that there are many people that will not take the vaccine. And I don't know if you saw this, but if you think about the setting where vaccine is so critical, it's long-term care, right? So many people have died in long-term care. It's been really heartbreaking. And yet, I think the report I saw a few weeks ago is that 62% of people who work in long-term care have refused the vaccine. These are healthcare workers. All right. So in the community, you can imagine that those numbers are going to be quite comparable, right? Maybe even worse. Who knows? We are looking closely at that. It's many of the minority populations, the Latinos and Black communities, are the most fearful of the vaccine, and yet they're the ones hit the hardest because they have many family members who are essential workers. They live in dense housing. It's very hard for them to distance. So we need a better strategy for making sure that the most vulnerable patients that we have are able to get the vaccine. And we believe a big part of that means getting community pharmacies the vaccines who serve those neighborhoods, because it's going to be hard for many of these populations to get online and get the time to sign up like you and I would, right? They're working sometimes long hours in the day and have limited access to online resources. So if they can just have their local community pharmacist tell them when their time is up and give them their vaccine, that would be a huge game changer for that group. So I just want to share with you, one of our faculty members is trying to come up with creative infographics to explain the vaccines. I love this one. It's a chart about, and of course this applies to the 2-shot vaccine, not the single Johnson & Johnson. But what he tries to explain is, how does the vaccine work? It's like cooking, right? In the case of the COVID virus, it's made up of 26 ingredients. The vaccine is targeting one ingredient, the spike protein, right? And so number 3, it says, your body bakes many of the one ingredient, right? That one focus on the spike protein, and then eventually creates these antibodies that then eliminate or deactivate the virus if you're exposed to it. So I like the graphics and the creativity. We're just trying to figure out what works best in terms of communicating how the vaccine works to people who are hesitant to take it. And we have several student groups that are working on educational materials to further debunk vaccine concerns. So I'm going to skip this. I was going to give you a patient testimonial, but I know we're limited on time. Maybe the best thing we can do is open it up for questions.
Okay, thank you so much. And I do see some questions in chat. So I'm going to start and then I'm going to turn it over to Jerry. We're going to alternate. The first one I got from Celeste Anderson. Her question is, how many dosing errors are due to testing on men and not women?
How many dosing errors? Are you referring to dosing errors for medications, like chronic disease medications?
I don't know if Celeste is here, if she can elaborate. I'm basically reading what she put in chat.
Yeah, I'm trying to interpret it. Is Celeste available to perhaps clarify the question?
Celeste, are you?
Yeah, I'm here. So
great.
frequently medicines are tested on men, and I've actually gotten tons of medicine with bad reactions because they're giving me too high a dose. And
Yes.
Part of it is later finding out that many of these aren't tested on women, so there wasn't an appropriate scale. And
Yes.
I'm wondering whether that's being rectified or whether that's still an issue.
Yeah. What a great question. It has been a tremendous issue, right? For women for certain, but also for minority groups, right? A great example is some of the statins. The maximum dose should be half for Asian populations. That wasn't well studied, and initially many Asian people were toxic when given the usual max dose of statin. So you bring up a tremendous point. The short answer is yes. There's been now good recognition that we need better diversity in the populations that are studied, so we'll understand the safety profile of these drugs for men and women, for different cultural and ethnic subgroups. And I'll add to that, even in the case of cardiovascular disease, the presentation of something like atherosclerotic cardiovascular disease in women is very different than men, right? And yet very few people emphasize or study that enough. We have an expert that we have in one of our groups who shared that the most common symptom that women present with heart disease is fatigue. And she turned around and said, how many women would say that they have fatigue, right? And of course, it's so common that I think most women wouldn't even recognize that. And yet that is the early hint, right? So I think everything from disease management to treatments, there is that recognition that we need to do better. And I think the vaccines are a good example of that. There was a very conscious effort to represent a broad array of cultures and genders to make sure we had that data available. So yeah, definitely with older treatments, it lacked. With the newer treatments moving forward, it's done much better.
Okay, Jerry, you want to take the next one? Jerry, you need to unmute yourself.
You still
Uh-oh.
need to.
Jerry, could you unmute yourself?
Yes. I
Okay, great.
tried. Somebody re-muted me. Okay. Second question is from Bianca Rosales. Does J&J have the same load of antibodies? Can you explain why only one vaccination is required for the J&J vaccine?
Okay, great question. J&J set out to create a one-shot vaccine. It's pretty simple as that. So their protocol, just based on their experience with vaccines, their understanding of immunity, they were confident that they can deliver a vaccine that could get it done in one shot. Now, I'm glad you raised that question, though, because you saw the initial results, right, from the J&J study. I believe it showed that there was a something in the neighborhood of 72% efficacy rate in the US. And people saw that and said, whoa, that's a far cry from 90 to 95% that we saw with Moderna and Pfizer. It sounds like this vaccine is inferior, right? Think about this for a second, though. The J&J studies came significantly later than the Pfizer Moderna studies. That's important because we've had many more virulent variants develop of the virus over the course of time. That means J&J had a much rougher playing field than Moderna and Pfizer did. So who's to say that if Moderna and Pfizer were studied in the same time period, that they would have similar results? They might have. Probably most importantly is prevention of serious disease was 85% in terms of efficacy with the J&J vaccine. Phenomenal. And there were 0 deaths in patients who received the J&J vaccine. So, if you were to ask me, would I be particular on which vaccine I take today? I would not. They're all 3 fantastic vaccines. Keep in mind also that with the flu vaccine every year, we hit about 40 to 60% efficacy. And we think we're thrilled when we hit 60%, right? So we've been a bit spoiled with the early Moderna and Pfizer results. Overall, these are 3 fantastic vaccines. And I should also add that J&J is looking at what happens if they give a booster. They haven't completed those studies yet. So maybe down the line, we may end up with 2 shots, but at the moment, 1 shot is quite effective with J&J.
Okay, I'm going to ask a question from Jeanette because this goes to a non-COVID related thing, but very significant with your lecture. Is there a reputable website that we can use to determine if there are drug interactions among the prescriptions that a person takes?
So there are, and if Brad wants to chime in on this, he can too. They're not easy to use, and because in many cases, you can go to a website and punch in drugs, and in some cases, they'll spit out this long list of drug interaction concerns, but it may not stratify them according to risk. It may not be able to say, this is very probable and concerning, these are intermediate, and these are low risk. Some do that. The ones that I work with do have those capabilities. Others do not. On top of that, they don't always have the most very up-to-date information, right? So I think there are some that are out there that, and if you'd like, I can find some of those later and send them to you, to this group. But I would just keep it simple and ask a pharmacist to do the work for you, because they really are up to date with the latest research. They get all kinds of concerns and flags from the FDA about medications, so they can incorporate all that into an evaluation of all your medications. And then keep in mind that some of the concerns with your medications also relate to your diagnoses. So there might be a generic, these could be concerning, but based on your particular conditions, there are some things that maybe you have to take that by the book may look risky, but in your case could be perfectly fine. So I don't know, Brad, do you have any comments on that? And again, this is Dr. Williams' expertise. I don't know if he wants to add anything.
I don't see him.
Okay, anyways.
Okay, Jerry, you want to go next question?
Yeah, I'll leave Katie's question for you, and I'll ask my own question.
Okay.
Following knee surgery at USC, I was sent home with 120 tablets of hydrocodone, Norco, which I consider a dangerous drug, approximately twice the quantity that I needed. I only took it for the first 5 days or so. When I tried to return the medicine for disposal at the USC Health Science Campus Pharmacy, they would not accept it for destruction. Why is that, and can you change that?
Yeah. So now my expertise is not in policy that relates to medications and disposal, but I will tell you that that's been a source of frustration for quite some time. There are places where you can surrender medications. There aren't pharmacies, unfortunately. It doesn't make any sense, right? When I practiced more regularly as a pharmacist, we were able to do that. The laws have changed. There are, obviously concerns that can happen even within a pharmacy when medications are returned. And it's not, I don't have the right answer for you right now. I do know that there are certain locations across the county that you can look up online that will take them, but they generally are not pharmacies. Yeah, it seems counterintuitive. It seems like it would just make sense for the pharmacies to be able to dispose, but yeah, it's a regulatory nightmare in pharmacies, right? What pharmacies have to do to ensure that controlled substances are accounted for is very difficult within the pharmacy. If you add returning controlled substances, it just becomes even more complex. So I don't mean that to sound like an excuse, but there's just too many regulatory blocks to make that easy. And I will find you that link for where you can return those medications. Okay.
Thank you.
Thank you.
I'm going to go with, there's two questions that are similar. And one, the person put it in, Pamela Corley put this in when she signed up for the lecture. And it's similar to one that Katie's asking. Pamela Corley's question had to do with an allergic reaction to Moderna, particularly the second dose. Katie's was, let me read this. Katie Beck, why does it hit those of us in middle age? I don't think Katie's middle age. I think she's quite young. Harder than older and younger. So those two questions relate to, I guess, side effects from the vaccines.
Yeah. Okay. So, and that's a great question because if you haven't already heard or you haven't already experienced it, the second shot of the 2-shot mRNA vaccines, both Pfizer and Moderna, can be a walloper, right? Without question. And I would, I see some nodding heads. It's actually a good sign. It means that your body is reacting and producing antibodies, right? So some experts would argue that the fever that accompanies the second shot in particular is actually a good thing, and would recommend don't suppress it entirely. If you can bear it, because that raised temperature is a sign that everything is happening the way it should. It is very uncomfortable. So I knew that going in. I had a really bad reaction to the second shot. I had fever, chills, myalgia, everything. I refused to take pain meds or anything until I just could not handle it anymore. So after about maybe 30 hours or so, I took a Tylenol. I had to, but that's all it took, right? Because I think everybody I've spoken to who's had that kind of reaction said, well, it lasts about a full day, maybe a day and a half, and then it dissipates pretty quickly. And I hope that's been the experience of any of you that have had it. So I wouldn't call that an allergic reaction, though. That's actually an expected reaction. There have been very few allergic reactions to these products. I know that there is some fear of the most concerning one, which is anaphylaxis. It's happened very uncommonly, and if it ever happens, it happens within 30 minutes of the shot in just about every case. So that's why if you tell someone when you're getting the vaccine that you've had a history of anaphylaxis, they'll make you stay for 30 minutes afterwards to watch you to make sure everything is fine.
What is anaphylaxis, please?
Oh, sorry. It's basically where your system starts to clamp down, and all of a sudden your airways tighten up. You can't breathe, right? You start to swell up in the face, right? It's very treatable though, right? It's on site. We have professionals with epinephrine, which will resolve it immediately. In just about every case, it can be resolved on site. In a few cases, patients had to be sent to the hospital, but it resolves with pretty minimal interventions. Yeah.
So Celeste Anderson has asked if you have no symptoms after the second COVID vaccination,
Okay.
should you
Oh,
be concerned?
I knew somebody would ask that. That's a great question. Not at all. So, an example, on the day I got my second shot, our dean and our 76-year-old COO had the same second shot on that day. They both did great, and I suffered. So no, I don't. I think it doesn't mean anything. People respond differently to the vaccine. For the most part, I believe I saw that about 80% of people who get the second shot will have some kind of reaction. 20% won't. So no, it doesn't mean anything.
Oh, okay. We have a question from Dixie Fisher. Are all pharmacists created equal? This is probably a question you don't really. For example, is my local CVS a good source for reviewing meds, or should I go to a USC School of Pharmacy member?
Well, if they're a USC grad, they're superior.
Oh, there you go.
No,
Those things are in the back. We can't see them.
So, I think it's a great question. And I'll be very frank. The answer is no. Some pharmacists are much more trained to do a full review of meds, and some are not. So I would say, should you go to, you could. There are some great pharmacists at CVS. I'll be very clear about that. We have some fantastic alum, and for the most part, they're great pharmacists. Just like physicians, they're great pharmacists, and they're mediocre pharmacists. If you have a pharmacist that you trust that's been giving you good advice, whether they're from CVS or anywhere else, yeah, you should absolutely go with them. But we would be happy to at the School of Pharmacy to provide reviews if you'd like. All the pharmacists at our USC pharmacies are highly trained, for the most part, residency graduates, and they do this all the time.
Okay. I think we have covered the questions in chat. So and we are right at 1 o'clock. So I'm going to thank you for speaking to us and thank everybody for coming. 41 folks showed up to listen. I guess 40 because you're the speaker. And I want to thank you all. As we talked about before, we are trying to do one of these lectures every month with the Retired Faculty Association and the Staff Retirement Association. So I'm going to turn it over to Jerry, who's going to talk about what's coming up for our next lecture. And thank you again, Dr. Chen. It more than lived up to what I was hoping to learn. And look, everyone's applauding. We've gotten nice things in chat. So thank you. This has been fantastic.
It was a pleasure to meet you all. Thank you. Have a great weekend.
Okay, so I'm turning it over to Jerry now for the final adieu.
Thank you. My colleague, Calvin Lau, has been discussing the possibility of a lecture by Professor Rajagopalan from the School of Business on Friday, April 9 at noon. That's Friday, April 9. And Dr. Rajagopalan is a specialist on supply chain issues. And I believe they've been discussing the supply chain for creation of the COVID vaccines and possibly their distribution as well. So when we have a formal title, we will be sure to get that information out to everybody through the Emeriti Center. Thank you.